Hi, I'm Desiree Chappell. Welcome to Top Med Talk. It's Tuesday, and it's time for my roundtable. Have a listen and enjoy.
Top Med Talk.
Hello, I'm Desiree Chappell, and this is Top Med Talk. We are at the third EBPOM Master's Course of Perioperative Practicum here in Dallas, Texas. We are very privileged to have a very special guest with us here at EBPOM USA to be talking and doing a deeper dive into enhanced recovery. I'd like to introduce Dr. Sabry Ayad. We were privileged to have a little bit of a conversation about enhanced recovery and what you've been doing with that, and the fact that you've actually been one of the pioneers in enhanced recovery here in the U.S., and I'll let you tell how long you've been doing it.
Sure.
Because really it's only been here for around 5 to 10 years, something like that. Sabry, if I may.
Yes,
yeah.
please. Thank you.
Tell us a little bit about your background.
Well, thank you, first of all, for having me, Desiree and Monty. Really appreciate having me here. My name is Sabry Ayad. I'm one of the staff anesthesiologists at the Cleveland Clinic. I've been with the Cleveland Clinic for over 23 years. I'm a professor of anesthesiology at Cleveland Clinic Lerner College of Medicine in Case Western, and I'm also a professor of anesthesiology at Ohio University. I am the president of the Cleveland Society of Anesthesiologists, and I'm a member of the Outcomes Research Group that you presented a lot of the research coming from there. How did I start with enhanced recovery after surgery? Yes, it's been a long time. It's a funny story. As a member of the Board of Governors and Medical Executive Committee at my hospital, I was privileged to sit down on several committees. Back in 1998 and 1999, I planned on introducing my guidelines and protocols for enhanced recovery after surgery. I called it back then Pain Attenuation Protocol. If you even go into my template right now at the Cleveland Clinic on the website for CPOE, you'll say Pain Attenuation Protocol that has the basic information about enhanced recovery after surgery. So how did it start? I got in touch with my colleagues, the chairman of orthopedic surgery and the chairman of cardiac surgery, and we talked about how we can have better patient care. It was a completely alien concept back then, how we can start something that, if it ain't broken, don't fix it. So the whole idea was, how can I convince everyone to get on the same new concept? Patient satisfaction was very important. Patient outcomes was very, very important for me. So I brought the idea of incorporating so many variables, different families of medication, different families of interventions into cardiac practice and orthopedic practice. Why did I choose these two first? Because we had the highest number of orthopedic and highest number of cardiac surgery back then. Sitting down, explaining this to the administrators was the hardest part. This new anesthesiologist coming and talking about all these new changes. Yeah, why are we doing this? Morphine is a few cents. Why are we getting all these medications, all these interventions? So it's almost like a challenge and a bet at the same time with the CFO and with the administrators. Are you going to proceed with this? We need to see some, return on investment. I said, give me 6 months and I'll prove it. With the support of the Department of Orthopedics and Cardiovascular, I started my protocol, and I was, happily invited back to the Medical Executive Committee, and I shared my results. Back then, a decrease in the stay in the hospital was not an issue because you get paid every day for every day that you stay in the hospital. There was not a lot of bundling like what's happening right now. But was very important, the fact that reducing the stay in the hospital, reducing side effects, getting the patient in and out very quickly, we were able to market our better care and best practice models from all the hospitals around so we can get more referrals. And that was something extremely important. We dropped the stay for orthopedic hips and knees in an average a day and a half back then. We also were able to extubate patients on the table. We're doing the fast track for open heart surgery, treating it exactly like what you're doing in lab chole. Most of my patients didn't get more than 2 mLs with 100 mics of fentanyl throughout the case. We're doing parasternal subfascial block and giving them a mixture of medication, including preempting them with the gabapentinoids, giving them acetaminophen before. So right now, every new medication that I have, I add it to the armamentarium that I have, so I can decrease the incidence of reliance on opioids, and it can cause a lot of side effects.
So we have also Monty Mythen, editor-in-chief of Top Med Talk, who is joining us. And Monty, you've been doing enhanced recovery for a little bit too, haven't you?
Well, I've been around good people who enable enhanced recovery. Why does it take so long to catch on?
Yeah.
Getting people to buy into the idea of these people are not very flexible. you need to have a consensus. And once you have the consensus, you have to sit down with every member of patient care. Pharmacy, administrators are very important. Physicians, surgeons, internal medicine, even perioperative care nursing, very important to get everyone on board. If you don't have buy-in from everyone and you have your own guideline and everyone would have a vested interest in it, it's not going to work.
Have you seen any bad things happen with enhanced recovery?
You know, the whole idea is you have a lot of patients, a lot of physicians who are set in their ways. If they are set in their ways and you have a standardized protocol and they say, no, we're not going to do this, you can see some, different, maneuvers that happen, and that can cause problems as well.
And do the patients like it?
Patients do like it. And that's something that we do ahead of time when you sit down with the patient and explain to them. Setting the expectations from the very beginning is very important. There is nothing that you can get into surgery and you're going to have zero pain at the end. So if you set the expectations from the very beginning, and that's why we have a class from before for hips, knees, any type of surgery, you tell them exactly what's going to happen. It's like a day camp before. And explain to them what they should expect, their expectation is set at this level. They will have some discomfort, but hopefully we'll take care of that.
Now, one thing I've heard some people mention in the United States of America as they get going, they talk about patients that are suitable for the enhanced recovery pathway.
Sure.
Whereas our experience was the patients that are allegedly least suitable for the enhanced recovery are the ones that get the greatest benefit.
Yeah. I see both points here, which is very important. Of course, we get rid of the emergency and the trauma and all the stuff which we do a lot of. And when we mentioned before about the gunshot wounds, we do see a lot of them, unfortunately. So all these, when you stratify a certain subset of patients, if they fit in the guideline that you have, they're not outliers, I think they would fit. But also the fact you mentioned that some of the outliers, they can also benefit if you get them in line with the standardized protocol.
Because we just went for we went for 4 major lines of enhanced recovery: the joints, the major gynae cancer surgery, the major urology cancer surgery, and the major colorectal, where it sort of started.
Yeah.
But nationally, we said, we're not going to cherry pick any of those. It's all in.
Yes.
And it was those multi-comorbidity, older, high risk, really, you're going to do this to them, patients that really, really benefited, whereas the ASA grade 2 having a right hemicolectomy, you can't hurt them really.
It's absolutely. ASA 1 and ASA 2s would definitely benefit for that too. So let me give you an example. I published a study a couple of years ago, and again, it goes back to the fact that you have to have the surgeons in line. So we have surgeons in the same division, colorectal surgeon, abdominal procedures, and they say, I totally believe in thoracic epidural as a treatment. Other group from the same division would say, no, IVPCA demand only narcotics was the best. So I said, why don't we do enhanced recovery after surgery with my protocol and look at even tap lock, introducing tap lock. So we did go back and we reviewed the data on enhanced recovery after surgery. Not only did the patient who had the tap lock with enhanced recovery after surgery show non-inferiority to IVPCA and epidural, but the patient who had the epidural infusion, they stayed in the hospital for 2 more days, more than anyone else, because by protocol, you have a thoracic epidural in being infused, you're not allowed to walk. So they ended up staying in bed for a longer period of time, have higher side effects from opioid-related side effects, and the highest amount of opioids being used, because whether they like it or not, through the infusion with local anesthetic, they're getting fentanyl as well. So that's something that caught the ears of a lot of administrators, because they look at this as, okay, economic data, staying in the hospital for 2 extra days. Each extra day is $2,834.
20 years ago, whenever you were starting this to yourself, did you think, were you still looking at the multidisciplinary team and doing that there? Did you think it was easier to do it back then than it is now?
No. It was difficult. There's now a lot of talk, a lot of societies right now talking about this, a lot of research. It was very important for me to sit down with every member, and it took a lot of time convincing everyone. But finally, I was able to successfully do it. Up until now, every new drug that I research, every new procedure that I do, I actually add it to the armamentarium. So it's definitely a big multimodal approach. And I'm definitely looking forward to, IV gabapentinoids in the future, IV COX-2 inhibitors in the future. All these medications will add up to my, my armamentarium of how to deal with other medication.
How did you get buy-in from the people that you were working with? This is something we talk a lot about on Top Med Talk and about enhanced recovery, and that's really important to try and figure that out.
Sure, consistency and persistence. You have to go and sit down with everyone. Key people are pharmacy, nursing, administrators, and surgeons. Very, very key. And you absolutely have to have the answers that they want. If you're going to talk to nursing, you explain to them what's benefit for them. You talk to surgeon, you have absolutely talk to, and surgeons right now are also under tremendous pressure of getting a patient in and out of the hospital very quickly. So it's totally different from before when everything was volume-based. Now everything is value-based. But it's very important to share all your information. Now, one thing that administrators and people in the business of administration are important. Cost efficiency is very important. More than anything, you have to show them how much you're going to be saving.
So if I heard your list again, you said pharmacy, nursing, surgeons, administrators. We're repeatedly told as anesthesia providers that we're the problem.
I disagree, even though right now every surgeon would tell you it's always the problem of anesthesia. I don't think so. I think we are actually the link. We are the perioperative medical care team that takes care of everything. We're the link to linking everything together.
But there's a recurring theme, and it crops up in the literature the whole time, is that if you take your foot off the gas, if you're not showing the data the whole time,
yes,
people lapse to about 60% pathway compliance.
That's true.
And it seems as though there's a little bit of passive aggression in there. There's possibly a little bit of forgetfulness, but most of it's sort of maverick behavior, like I know better. I know it's driven by boredom or creativity, or do you not see that? Do you have 100% compliance?
I do see that, and I see a lot of egos also. Everyone who says, no, my technique is the best. If you don't incorporate it, I'm not going to be involved in it. So yes, you have to have a lot of convincing and a lot of sitting down with them and explaining them the overall benefit. Because standardization, believe it or not, is very important.
Yeah.
And because we read quite a lot about your big data, your electronic health records.
Yes.
And we've seen publications about the use of electronic nudges and surprisingly disappointing results that flagging up these things and in your face. What?
Yeah.
Banner fatigue.
You get fatigue at the end. It's true.
And it didn't make any difference at all.
And eventually, when you talk to people, caregivers, and you say, "Look at this data," people are not going to believe this. So that's why I'm trying to introduce blockchain, as I mentioned yesterday, blockchain technology, and looking at healthcare outcomes, and moving it from a platform of looking just at the data, but also authenticating data that would help me at the end, coming up with outcomes that would help.
I know a little bit about the blockchain. I can just I can say it, and you can explain it in a bar, maybe.
Sure.
I can be dangerous, as you say. That's quite right. How's it going to help?
So let me just give you a brief description of how blockchain works. You're creating digital data that is authenticated between the person who's providing the data and the person who's accepting the data. 100% authenticated. So if you're looking at EMRs, for example, there's a lot, since we moved from paper to paperless right now, a lot of copy and paste. And copy and paste is a big problem.
Yeah.
You see a lot of problems with that. So the data, you can see in the diagram, you see this patient is a female 54-year-old, and you're looking and it's a patient, 74-year-old man. So it's something you absolutely have to have authentication of the data. So number one, medical errors will decrease when you have blockchain technology, and when you remove the middleman completely from this. The patient would know exactly what they're getting into, and the provider will know exactly what they're here for. So all the side effects, like foreign body, operating on the wrong side, wrong patient, all that would be authenticated, and we'll get rid of that. That's part of it. Supply chain is a big, big issue. Financials is also another big issue. We definitely can talk about this for hours and hours. Blockchain for healthcare is just at the beginning stages, but it has tremendous potential.
I can understand the provenance of the data, the provenance of the intervention, the provenance of the cut and the paste.
Yes.
Allows you to work out who screwed up where. How does it stop the screw-ups?
So if you have someone at the beginning putting the data in something called the node, and the node is the interval between the patient who is being seen and what's data being there. And this node will authenticate exactly what happens to this patient during the visit, what happens with the history, what happens with the physical exam. All the labs will be in this node exactly. And this node will be shared only by the patient and the caregiver. Only. No one can change it. So if you go back in and you try, you're not allowed. You try to change the data, a 54-year-old would become a 74-year-old, that cannot change. It's authenticated 100%.
So you can't.
You're getting rid of the middleman completely.
So if I may, Desiree, so the patient is the owner of the node.
That's correct.
Does the patient also know when you are and aren't complying?
Yeah, absolutely.
So they can.
It's mutual.
Their ownership of the fact that
exactly 100% trust system.
Yeah, you weren't going to give me 5 liters of fluid, but you did.
Yeah, exactly. Yeah. They will know. They will know.
Can we talk about that, Doc?
Absolutely, there's something wrong. Tell me about it. But again, eventually, just imagine all this data that you have. And we're talking about data, we're talking about machine learning, predictive values, and predictive analytics. That's exactly what we're going to see happening in the next 5 to 10 years. Actually, it's happening right now, too.
We'll be hearing about that shortly.
Oh, we are going to be talking about AI next.
Yeah,
so.
yeah.
And you've been using that at the Cleveland Clinic.
I am.
Yeah, I was
one
going to say.
One of the largest sites in enrolling patients so far. It's a good study so far. Yeah. Very good.
You mentioned about standardization, and we all know that you have to have standardization and compliance of those things. So, in your experience, well, first of all, we heard from Carol Peden yesterday about the Epoch Trial.
Yes.
And how, whether it was shown to be successful necessarily when you have so many different components of an enhanced recovery pathway, and that didn't make any better outcomes, right? So that the enhanced recovery pathway didn't. But I think what they were attributing that to was there were so many components. Now, Henrik Collette said you only need, 5 basic components. Where do you stand in that? Like, what are some major points in a pathway that are important to you and that you've seen in your experience throughout the time that really make a difference?
Patient outcomes in general, what you're looking at, what's important if you look at the readmission rate, patients who come back with a medical error that happens during the process or even immediately within 30 days after discharge, patient who stayed longer than they needed. All these are penalties by the Central for Medicare and Medicaid. All these are very clear infringements of what happens to a patient. There are smaller outcomes that you're looking at. Anything that goes wrong, severe PONV that caused the patient to stay, opioid-related side effects. The patient had respiratory distress and ended up in the ICU. Serious side effects like patient could have a mortality or a morbidity at this point. All these are outcomes that you need to look at. There's also a fact that I see a lot of my colleagues talking about when you have all this multimodal approach and you're talking about polypharmacy. You worry about something, what's going to happen when you have an infusion of IV esmolol, IV lidocaine, IV ketamine, tons of medication for a 70 or an 80-year-old patient. And that's the population that we have right now. 80-year-old patients with an acuity index of 1.94 with tons of morbidities. We don't see the ASA 1s and the 2s anymore. Everything goes to the surgery center. So always ASA 3 and 4 all the time, and lots of E modifiers as well. So you worry about this. And you have to keep in mind, you as a consultant, you have to look at every case, still individualized medicine, but when you have a protocol that would tell you what you can use, and it's up to you. For example, I usually use ketamine for IV infusion. If you have someone who has a history of post-traumatic stress disorder, psychosis, psychiatric history, that's a contraindication to use ketamine completely. Then I would go back and start them on an IV esmolol, IV lidocaine, magnesium, anything that would help. So I'm the consultant, I'm not going to use anything that would harm the patient at this point.
Yeah, but you get to have some variability.
Exactly.
So multimodal pain management is a big
Very
component.
Important. Yes.
And what about fluid?
Fluid, goal-directed fluid therapy. I'm working on TJ Gann with several studies right now. I still believe, and I saw the comment from your past a guest regarding, is it colloid or crystalloid? I think so far, right now, what we know is if you severely dehydrate your patient and have severe restrictions, you're going to have AKI, and that's something that we don't want to happen. I'm doing 3 studies right now. I actually finished one of them regarding AKI for cardiac surgery, and I'm looking at the incidence of it. So definitely you don't want someone who ends up with an AKI. So
are you routinely using any of the biomarkers that suggest renal stress as opposed to renal injury?
One of the studies I used the renal markers, I used the nephrocaps, not the second one. The third one will be using it. That's something that we're going to use. But it's also important when you're looking at for non-cardiac surgery for MINS, for example, you worry about a lot of stuff. I mean, even a small decrease in the blood pressure that you can lose agony, or we're not going to even give fluids, but you end up looking at troponin levels, and it could be harmful to the patients. So we're doing a couple of studies right now looking at the data. One of them is POISE-3.
So, I have a question as far as, we talked about fluids, but, we talk about fluids and part of, hemodynamic management and writing, protocols.
Yes.
Do you have, hemodynamic parameters that are written into the protocols that you have, the pathways?
We do have parameters right now. A couple of the studies that you're doing, as you mentioned, one of them is looking at the data from the optimum blood pressure, arterial blood pressure that you have versus high versus low. A couple of studies are going right now, and I should share some results with you, hopefully within the next 6 months.
So the more targeting to...
Not high hypertension, not hypotension. So we're actually looking at 3 arms. Normal blood pressure, high blood pressure, and low blood pressure with parameters.
And you're having those as targets, are you?
Randomization.
Right. Now, how high is the high?
So anything above 160, anything at
Systolic.
Yeah. And lower would be lower than 90. And in the mid one with a mean arterial blood pressure of 65, that's what we want.
Because we did a journal club on the Engages study.
Yeah.
Which was the bispectral index to adjust vapor concentrations and delirium.
Sure.
And the striking thing that bleeps out at you at that trial is, and I wasn't surprised about the delirium result personally. I don't think it's biologically that plausible, but the huge difference in mortality was really striking.
Yeah. So, and that's something
now,
that we have to.
We know we've got to be careful because it's single center, relatively small. Those differences can happen by chance.
Yeah.
But that's a lottery chance for that.
I agree with you. A new multi-center study, larger number study, would be very, very doable for a case like this.
And when we went through it, one of the striking things is that there wasn't a difference in if we read it correctly, in the hypotensive episodes, but there was a difference
in
high blood pressure.
Yeah, high blood pressure, hypertensive. Yeah,
and that's plausible, isn't it? That is biologically
very much so.
Highly plausible. And there was a lot of hypertensive patients.
That's true.
So for those people not tracking, if you read the appendix, you'll see that one of the things that's statistically significantly different is the patients, and correct me if I'm reading this incorrectly, who had BIS monitored ended up with lower vapor concentrations, and they ended up with many more episodes of higher blood pressure.
It's true.
So there was no difference in the low blood pressures because probably you're so attuned to it, or they were so attuned to it, they're treating the low.
They worry more, exactly. They worry more and they treat more the hypotension than the hypertension.
So that your trial will. Is a big trial?
It's a huge trial.
Can you give us some more clues?
It's part of the POISE 3 study.
Okay.
We're trying to get it in it's almost 33 countries right now.
Yep.
Tons of patients. Very, very good study. So hopefully we'll get some results, at least preliminary studies, before the end of the year.
Is the protocol out on clinicaltrials.gov yet, or similar?
It is on. Yeah. Yes.
So we can read up with it.
Yes.
POISE 3.
Yes.
Fantastic. Thank you.
Yes.
Interesting. So, we're talking about utilizing the BIS to kind of help manage, as a tool. Because people say BIS. Is that part of your protocol that you?
So I don't know if there's going to be a lot of the attendees here who might disagree with me, but I never used the BIS monitor as an awareness monitor. Since it was introduced in the 94, 95, I always used it as tailoring the anesthetic. Why would I drive someone to below 20 reading when I can get between 50 and 60, the same results, waking up faster? And I'll tell you another, maybe I shared that with you. When I have visits for Joint Commission every 2 years to accredit my center, the head of the Joint Commission surveyor who came and sat down with me said, I've noticed something very interesting. Your patients are very awake at the end of surgery, and they actually sometimes bypass phase 1 of PACU. What are you doing? I said, I don't drive the BIS lower than 40 or 50. That's it. So I see other facilities where they drive the BIS to 20, 15. That entails more side effects from increased general anesthesia, side effects from opioids, side effects from the reversal of muscle relaxation. All this together can cause problems, keep in the hospital for a long period of time. Definitely had side effects in phase 1, and they actually are very groggy and very drowsy by the time. So he actually noticed that because we are allowed to have the note of post-operative note within 15 minutes, and he looked at it and said, that is very, very interesting. You are one of the few sites that I saw, and your patients are extremely awake.
That is actually very interesting. I mean, with enhanced recovery, it can make a huge difference.
Absolutely, and again, use it as a mechanism to tailor your anesthetic, the amount of anesthetic.
Well, and if they're awake and moving around a lot sooner, we're getting them up, drinking, and eating,
sure.
mobilizing, which brings us to another point of enhanced recovery.
Yes.
A pillar, I would say, that Monty was talking about is getting them up, moving, and with your cardiac patients. With your hips and joints, all that obviously has been a
and then we expanded to colorectal surgery, abdominal procedure. Right now, with the advent of going for robotic surgery and laparoscopic surgery, we have minimal incisions that can help with recovery after all. And then with the medications we give, enhanced recovery after surgery, running them on infusions. Typical cases for our site, because we're a training facility as well, a big institution, is between 2-3.5 hours. So I have time to infuse. Versus a surgery center, when you have a case an average of 40 minutes, you don't have time to start an infusion or anything like that.
Yeah. And then eating and drinking.
Very, everything.
Component.
Gone are the days that you have to fast, have your patient fast for 12,
all
14
your
hours.
patients, NPO time, 2 hours?
2 hours right now, they can have, either, some of the carbohydrate diet or anything like that within 2 hours, 8 ounces. And we let them eat like 6 hours or beyond that. So they can eat, that's not a problem. And then once we get them, we start them on the gabapentinoids and the acetaminophen and the celecoxib.
Would you be prepared to go to no period of NPO?
No opioid at all?
No,
Yeah.
NPO.
Oh, NPO?
NPO. So in other words, because we talked about it before, the Great Ormond Street Children's Hospital and many pediatric centres have gone to zero
NPO. Also, yes, I saw these studies. Possibly in the future I can do that. I have to convince some of my surgical colleagues about that as well.
Do you think it's your surgical colleagues you have to convince?
Yes.
Because they always tell us it's you damn anesthesiologists.
No, it's my surgical colleagues that I need to. I can take care of my own anesthesia.
What do you think will happen?
Some of them would refuse. Some of them would look at data and say, they're going to be severely hypoglycemic or something like that, or hyperglycemic. So I'm not sure what they're going to be looking at that.
No. Okay, so we're going to be wrapping up here in just a little bit, but I want to know, what do you think the future of enhanced recovery for this country is?
Well, I think it's going to be stellar in the future. There's going to be more weapons in our armamentarium in the next few months, actually, where there's so many drugs being developed right now, so many more procedures, a lot of introduction to local anesthetic and blocks that would help minimize the pain. I'm a strong believer in regional anesthesia as part of the multimodal approach and part of enhanced recovery. I think it's here to stay.
Yeah, we could talk forever on that.
Absolutely, absolutely.
So I guess before I ask about the future, I could have said, where do you think we really are? I mean, what do you think the adoption rate of enhanced recovery is? I mean, you talk to a lot of people.
Yeah, 15 to 20%, because remember, out of the 5,700 hospitals in the United States, not all of them are big institutional academic centers and big, it's not. There are a lot of rural 5,700 hospitals in the United States. Almost 2/3 of them are not yet up to multimodal approach and stuff like that. I do provide lectures and education for these hospitals. They're a little bit behind, so they probably need to have increased the level of education that helps them get on the band of enhanced recovery after surgery.
Yeah. I'm always curious about how we need to communicate with one another so we don't all have to reinvent the wheel. I mean, if you've been doing it for a while and you know it's successful, I mean, there's literature, but about maybe specifics of each individual thing, and then ERAS works as a whole, but there's not much on how do we actually get it to work and how do we get it to stick.
To start a program
share
like
that
this,
with everybody.
absolutely. To start a program like this, it is expensive. Remember, I had almost a bet and a challenge with the CFO, so you have to go and convince people. And if you're in a rural area, you already have low reimbursement, and you're already starting several infusion and new programs, it's very hard for smaller. There's a lot of hospitals being closed right now.
Mm-hmm.
We're going to have to wrap, Desiree, because we're back on in 6-7 minutes.
Yep, that's right. So thank you, everyone, for listening. Thank you for listening at home. Top Med Talk at EBPOM USA this year in Dallas. Dr. Ed, thank you so much for sitting down.
Thank you so much for having me. Appreciate it.
Great to see you again.
Thank you. To see you again. Thank you so much.
Top Med Talk.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done. And it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. While you're there, get excited about EBPOM London 2019, the London Perioperative Medicine Congress. It's on July the 2nd, and it's one of many meetings that EBPOM organises around the world in order to communicate the perioperative medicine message. Have a look, ebpom.org/meetings.